Good evening, everyone. Welcome to the second session of the Diabetes Update webinar series. Today's webinar is on diabetes and cardiovascular disease and is brought to you by the Physician Learning Program and the Office of Lifelong Learning in partnership with Diabetes Canada Edmonton and Area Professional Sector Chapter. I'm Dr. Roshan Abraham. I'm a family physician and an assistant professor in the Department of Family Medicine in the Faculty of Medicine and Dentistry. The Office of Lifelong Learning is committed to providing the latest information, advice, and resources to support continued educational needs of healthcare professionals and their teams. Just before we begin tonight, I would like to go over some housekeeping slides. First of all, we acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. I'm pleased to introduce our three speakers for tonight. Dr. Rose Yeung is a clinical endocrinologist and associate professor in the Department of Medicine at the University of Alberta, Canada. Her research interests include diabetes, quality improvement in healthcare, and implementation science. She is a medical director for the Office of Lifelong Learning at the University of Alberta. Dr. Yeung is passionate about patient education and empowerment, co-founding the Edmonton Zone Diabetes Resources Review Committee, board member of the Type 1 Diabetes Think Tank Network, a consortium that brings together patients and healthcare providers to break down communication barriers and inform more humanistic practices, and co-creator of the educational website diabetes-pregnancy.ca. She values broad community engagement and was the 2018-2019 chair for the Edmonton Area Professional Section of Diabetes Canada and is a core committee member of the Alberta Diabetes, Obesity, and Nutrition Strategic Clinical Network. Dr. Darren Lau is an academic general internist and diabetologist at K Edmonton Clinic. He completed a PhD in clinical epidemiology in 2012 and his general internal medicine residency in 2019, both at the University of Alberta. He attends clinical teaching unit at the University of Alberta Hospital and has a modest outpatient practice consisting mostly of people with complicated diabetes. In his research life, Dr. Lau uses administrative databases to develop insights about the outcomes of medical care in people with diabetes. And finally, Dr. Donna Manca, who's a family physician and a professor and the director of the research program in the Department of Family Medicine at the University of Alberta. She's the director of the Northern Alberta Primary Care Research Network, or NAPCRN, a network contributing to the Canadian Primary Care Research Network, or CIPSN. NAPCRN extracts information from electronic medical records, cleans and structures the information for the purposes of quality improvement, surveillance, and research. Dr. Manca's research interests include primary care, implementation science, privacy, ethics, research networks, cancer and chronic disease prevention, screening, and management. She is a Diabetes Action Canada investigator contributing to the National Diabetes Repository. She's also a medical director of the Physician Learning Program and the medical director of the Better Training Institute aimed to improve chronic disease prevention and screening across Canada. I turn it over to you, Darren, to get us started.
Thanks, Dr. Abrams. It's a pleasure to be back for a second round speaking to diabetes agents with cardioprotective benefits. I really wish I could see the audience. I can't wait for the day we get back in person. I don't know if food used to accompany these events, but I miss seeing all of you and learning a little bit about who's who in the zoo, so to speak. But anyways, thanks all for being here and joining us for another diabetes webinar. Now, for the longest time, the only agent with evidence in terms of cardioprotection for diabetes was metformin, and that was way back when UK-PDS 34 was published in 1998. Now, these days, UK-PDS, it might not pass muster as a cardiovascular outcomes trial, and overall, the actual evidence for the effectiveness of metformin in terms of cardioprotection is considered to be somewhat uncertain. No one's going to do a full randomized controlled trial of metformin now because it's long since been considered standard of care. So it was quite a nice thing for the field when we actually did find more agents with cardioprotective benefits. And those specific classes of agents would be GLP-1 receptor agonists and SGLT2 inhibitors, which are going to be the subject of most of what we talk about today. So our objectives, we're going to describe how these two classes of agents work. We're going to sketch the evidence for the cardiovascular benefits of these agents. And then we're going to apply these agents to a motivating case, similar to what we did last week. And as always, I hope at the end of the talk, you'll take a moment to reflect on how you might ensure that all the patients in your practice benefit from these agents and Dr. Manca is going to cover some quality improvement related tools that might be of interest to you in those regards. Okay, I'll take the next slide. So just a reminder, this is the third webinar in a series of 4 in total. The upcoming webinar on deprescribing insulin gets into some nitty-gritty prescribing details, and I'm very excited about next week's webinar actually, so stay tuned for that one. But just as a recap, we did cover a lot of material related to the SGLT2 inhibitors during last week's talk on diabetes and chronic kidney disease. So at some points in the talk, what we might do is gloss over the SGLT2 related material and refer you to the previous talk where it may have been covered in a bit more detail. Anyways, with no further ado, I'll let Dr. Manca cover our motivating case.
Well, Mr. Denier comes in to see you, and he's well known to you. You're worried about him because he's had 2 myocardial infarcts at a young age, and he has diabetes. He's on metformin and glycoside, and his hemoglobin A1C is still high. He's also obese because he has a waist circumference greater than 40 inches, a lot of abdominal obesity. He smokes 1.5 packages of cigarette a day, and he's absolutely not interested in quitting. You've tried on numerous occasions. At his previous appointment, you became aware of excessive alcohol consumption. He was working from home with COVID, and he became quite anxious, and at night had trouble calming down and sleeping. And he found initially a glass of wine helped. It seemed to help him. Unfortunately, it escalated to 2 and then 3. And then he told you that he was taking at least 4. You suspect more. And his anxiety was not improving. So you talked about options, and he agreed to trial trazodone and cut down on the alcohol. And this worked like a charm because he did cut down to 1 glass of wine at night. So at this appointment, what you're really focused on is better optimizing his diabetes. And you look at his diabetic medication and you think maybe it could be better. You started him on glycoside, which could potentially help you apply for different medications on Blue Cross. But what medications could we consider in this fellow? What do we know about them? Next slide.
So that brings us to the diabetes drugs with cardiovascular benefit, as Darren had nicely introduced earlier. And so here we've just listed the ones available. And starting with the SGLT2 inhibitors in Canada, we have canagliflozin, dapagliflozin, and empagliflozin available. Dosing regimens listed there. And to keep things within time, all I'm going to say about SGLT2 inhibitors and mechanism of action this week is to say that they promote glucose and sodium excretion and have consequent effects on both glucose and sodium handling, and benefits on the blood pressure, on the blood sugar, on body weight. And as you can see from this somewhat busy slide, there are numerous beneficial effects on multiple organ systems seen with the SGLT2 inhibitors. So I will refer you back to the presentation last week where we got into this a bit more.
Now, this, of course, is, again, some material that was presented last week, but this is the data from EMPA-REG Outcomes, which, of course, was the cardiovascular, the CV outcomes trial of empagliflozin. And so these are the Kaplan-Meier curves, and you can see they split almost immediately, showing a benefit in empagliflozin for cardiovascular outcomes. And of course, when these results were first presented, it was quite a surprise to the field. How in God's green earth could a medication that lowers blood sugar have an immediate impact on cardiovascular events, which at that point were felt to be driven by atherosclerosis? Well, it turns out SGLT2 inhibitors, this is what we know about them now, they have pleiotropic benefits, including multiple mechanisms that help the heart out, that actually act immediately. And they include cardiorenal hemodynamics and altering the energetics of the heart, so there's a little bit more ketone use. From a heart failure perspective, they reduce fibrosis of the heart, they reduce afterload, they reduce blood pressure. So in a number of ways, the effects of SGLT2 inhibitors in terms of cardiovascular benefit transcend simple glucose lowering. And this sort of divergence of the curves has been noted in the other cardiovascular outcome trials as well. Now, the other cardiovascular outcome trials, of course, of the agents that we have available in Canada, for canagliflozin, that would be the CANVAS program. And for dapagliflozin, that would be Declare TIMI 58. So EMPA-REG outcomes, Declare TIMI 58, CANVAS. Those are the three CVOTs, cardiovascular outcome trials of the SGLT2 inhibitors. This is data from a meta-analysis of these three CV outcome trials. And you can see on the primary outcome of these cardiovascular trials, so that's usually a composite outcome called 3-point MACE, so major adverse cardiovascular endpoints. That's a composite outcome composed of CV death, non-fatal myocardial infarctions, and non-fatal stroke. And on this primary cardiovascular outcome, there was about a 15% relative risk reduction in all of the trials associated with SGLT2 inhibitor therapy versus placebo. Now, the surprising thing is, and this is a finding that's been robust across multiple trials, a very consistent 25% relative risk reduction in heart failure admissions associated with SGLT2 inhibitor therapy. So that's part of the cardiovascular benefit as well. And in fact, we now have a heart failure specific trial, so DAPA-HF, where heart failure was actually the primary outcome, and it was heart failure patients that were enrolled in the trial showing heart failure benefit of dapagliflozin in both patients with and without diabetes. So some decent evidence that your patients with heart failure benefit from these agents as well. Now, one of the things that comes out in the data is that the benefit appears to be obvious in patients with established atherosclerotic cardiovascular disease, so who already have a pre-existing diagnosis. This would be your secondary prevention population, and that's where you get that 15% relative risk reduction in 3-point MACE, and you have a pretty obvious 25% relative risk reduction in heart failure. The benefit is much less obvious, if it exists at all, in patients who don't have established cardiovascular disease. So it's multiple risk factors only, so that would be your primary prevention group. I would like to point out Declare TIMI 58. You might recall I mentioned it last week. This specific CVOT trial of dapagliflozin versus placebo featured about 68% patients in that primary prevention stratum. So again, no established cardiovascular disease, just multiple cardiovascular risk factors. And Declare TIMI 58 was non-inferior on its primary 3-point MACE outcome, but it did show significant benefit in terms of heart failure. And that's going to be important because the Diabetes Canada guidelines actually do create a space for prescribing these agents for cardiovascular benefit in patients with without pre-existing cardiovascular disease, so your primary prevention patient, and it's based on studies like Declare TIMI 58. We're going to come back to that a bit when we talk about the guidelines. Okay, let's head on to the next slide. Over to you, Rose, for GLP-1 receptor.
Yeah. So GLP-1 receptor agonists are the other class of medication that have been shown to have cardiovascular benefit in people with diabetes. And here we've listed the 3 medications: liraglutide, semaglutide, dulaglutide. As you can see, liraglutide comes in 2 dosage formats. Semaglutide comes in now injectable and oral, and dulaglutide comes in an injectable format. We've included these for reference so you can look back to look at the dosing titration as needed. So GLP-1 or glucagon-like peptide-1 receptor agonists work in a very unique and interesting way. So these work on the incretin hormone system. So what happens is when we eat food, that food is digested in our gut, and we secrete incretin hormones, GLP-1 and GIP, also known as glucose-dependent insulinotropic polypeptide and glucagon-like peptide 1. So these are the incretin hormones. And what these do is these promote glucose-stimulated insulin secretion from the pancreas, and they also suppress glucagon secretion in the pancreas, which helps to reduce hepatic glucose production by the hepatic glucose production. thereby lowering plasma glucose. And these are the main actions, but in fact, we know that GLP-1 receptor agonists actually have a multitude of pleiotropic effects. So they work also on the satiety center. And so this is what we call the gut-brain axis, where we understand that these hormones and these agents work to increase satiety and suppress appetite. They also have an increased energy expenditure effect. We also know they have specific cardiac effects. We know these drugs lower blood pressure. They increase myocardial contractility, and they can increase heart rate in some patients. So that is a caveat that we do have to watch out for with these drugs. These drugs also have effects on the kidney with increased natriuresis. They work on muscle to increase glycogen synthesis and glucose oxidation. And they have effects on the fat cells, where we see increased lipolysis and increased glucose uptake in the adipose tissue. When it comes to hammering down into the cardiac effects, we see that the cardiac improvements are seen through that risk factor reduction, through the weight reduction, as we've discussed, with the decrease in blood pressure. And as mentioned, that contractile improvement in the cardiac cells themselves. This optimizes cardiac energy consumption and has actually been shown in models to protect from ischemia and reperfusion injury. So this is really interesting mechanistic work that's been shown to have specific benefits on the heart. We also see improvement in endothelial dysfunction.
So these are data from a systematic review of GLP-1 receptor agonists. And from this slide, I want to make 2 points. Point number one is that, boy, do GLP-1 receptor agonists produce glucose lowering. So the first graph, you can see the degree of HbA1c reduction associated with each GLP-1 receptor agonist. And we're talking about HbA1c reductions up to about 1.5% or more. The longer acting agents have more benefit than the shorter acting agents, but even among the longer acting agents, there does appear to be some superiority to injectable semaglutide in these regards. Thing number two, GLP-1 receptor agonists are also associated with a meaningful degree of weight loss. And we usually consider weight loss to be meaningful in the obesity world with a minimal clinically important difference of about 5% or 5 kilos in most trials, since most patients enrolled in obesity trials are about 100 kilos. And you can see in terms of weight loss, by far and wide, the winners here appear to be semaglutide, both injectable and oral, associated with about that 5 kilo weight loss or more. Okay. So these are the data from the cardiovascular outcome trials of 3 specific GLP-1 receptor agonists. That would be liraglutide, semaglutide, and dulaglutide from the LEADER, SUSTAIN-6, and REWIND trials, respectively. And you can see there's about a 15% relative risk reduction in that primary cardiovascular outcome between all 3 trials. And this is very comparable to the cardiovascular benefits seen with the SGLT2 inhibitors in EMPA-REG outcome and in the CANVAS program. I'll take the next slide. This is a meta-analysis of all the CV outcome trials for the GLP-1 receptor agonists. Perhaps this is a little unfair since it included earlier agents that haven't been shown to have cardiovascular benefit, but even so, the meta-analytic overall pooled hazard ratio still demonstrates cardiovascular benefit, again, on that primary outcome of 3-point major adverse cardiovascular endpoints. Now, there's a couple of other things I want to bring out from this slide. The first thing is, much like with the SGLT2 inhibitors, the benefit appears to be most obvious in patients with established cardiovascular disease. So again, that secondary prevention population where you see that 15% relative risk reduction, the benefit appears to be much less obvious in patients without established cardiovascular disease, so with multiple risk factors only. and that would be that primary prevention group. I would like to highlight one particular study in these regards, and that would be the REWIND trial, which is circled, the result of which is circled there in red. Now, much like Declared TIMI 58, REWIND was a trial where actually about 2/3 of patients were actually primary prevention patients. So again, these are patients who did not have established cardiovascular disease, but did have multiple CV risk factors. And REWIND was actually positive on its primary 3-point MACE outcome. So Diabetes Canada has extrapolated these data to suggest a role for GLP-1 receptor agonists for cardiovascular risk reduction in primary prevention patients, so those without established CV disease, but who do have multiple risk factors. And we're going to see that when we go over the guideline slide. But bear in mind that this is a single study. And if you do look at the primary prevention subgroups and pool them, the overall meta-analytic odds ratio is still crossing the null line. So not quite as obvious. Okay, I'll take the next slide. Now, I want to spend a little bit of time to talk about oral semaglutide because I know you're all burning to hear more about it. I anticipate this as a question to come up later. So oral semaglutide, yes, it's a thing. And it's a spectacular innovation, this idea that you could absorb a peptide molecule intact through the stomach wall, where the acidity and the peptidases usually break down all peptide molecules. I mean, this is why you can't eat insulin, you actually have to inject it. And the innovation here is that Rybelsus is semaglutide, but it comes with a little moiety called SNAC. And SNAC and semaglutide, when they co-localize, they form a little bubble of neutralized pH that protects the semaglutide from gastric degradation. And when that bubble is located right on the gastric wall, that allows the intact semaglutide molecule to be absorbed through the gastric lining. And the practical correlate of this is that Rybelsus has to be taken on an empty stomach to have that nice gastric content. So you got to take it 30 minutes before food or other medications. I'll take the next slide. Pioneer 6 was the cardiovascular outcome trial of Rybelsus, or oral semaglutide. And on MACE outcome, it was actually non-inferior. So it demonstrated cardiovascular safety, but did not demonstrate cardiovascular superiority or cardiovascular benefit. On its secondary analysis of the secondary outcome, CV death, there was a pretty substantial reduction in CV death, but this outcome is considered exploratory because it was inferior only on the primary outcome. And as a result, Rybelsus has a label for glucose reduction only. Unlike semaglutide injectable, it does not have the label for cardiovascular risk reduction. Many of us also have questions about how effective it's actually going to be in the real world, given that it is another medication you have to take on an empty stomach. And for patients at elevated cardiovascular risk, where you're really going for that cardiovascular protection, it might not be your preferred formulation of a GLP-1 receptor agonist. Okay, I'll take the next slide. So that brings us to the guidelines. This is the Diabetes Canada 2020 update, okay? And it really streams your patients into two pathways. Pathway number one is the patient for whom you're really just looking for glucose reduction. They don't have established cardiorenal indications for special therapies. In that case, well, the sky's the limit. You got the whole armamentarium of glucose reducing agents available to you, but you might preferentially choose GLP-1 receptor agonists or SGLT2 inhibitors because they're quite safe and they're associated with weight loss. And in most patients with type 2 diabetes anyways, weight loss is pretty much a universally desirable thing. And the agents are also pretty free from hypoglycemia. But if your patient actually has established cardiovascular disease, then regardless of what their A1C is, I'm going to repeat that, regardless of what their degree of current glycemic control is, you really do want to prioritize getting them on an agent with cardiovascular benefits. Again, not necessarily for glucose reduction, but for the cardiovascular benefits of these agents. And that would be a GLP-1 receptor agonist or an SGLT2 inhibitor. Now, if they have a previous history of heart failure, same thing applies, except you really want to get them on an SGLT2 inhibitor. This slide is a little bit out of date. Actually, there's really good evidence now for using SGLT2 inhibitors in heart failure. So that should be kind of green across. Oh, it is green, actually. I see where Dr. Yeung is doing the little circle with her cursor. Understood. Perhaps I should have revised these red circles. They're not really in the right place. Okay, so again, if they have atherosclerotic cardiovascular disease or heart failure, SGLT2 inhibitors or GLP-1 receptor agonists, regardless of their A1C. Now, I want to highlight that last column on the right side. This is for patients with multiple risk factors, but who don't have established cardiovascular disease. So greater than 60 years old with additional CV risk factors, and what qualifies as an additional CV risk factor would be elevated waist circumference, hypertension, smoking status, strong family history, for example. Diabetes Canada says this is the patient that you also want to strongly consider getting them on a GLP-1 receptor agonist and maybe an SGLT2 inhibitor based on, respectively, the results from the REWIND and the DECLARE-TIMI 58 studies. Now, I know this is going to affect a lot of people in your practice, and I think it would be pretty reasonable if you were to start with the patients in the secondary prevention group first, recognizing that the absolute risk reduction you're going to see, so the number needed to treat in the primary prevention population is going to be a lot higher than the numbers needed to treat in the secondary prevention patients. I think we have a lot of work ahead of ourselves in terms of getting patients on these agents, and 100% those patients with established cardiorenal indications should be on these agents. All right, I'll take the next slide. This is a busy slide. It's there for reference, maybe in the QP if we want to go back to it and have a look exactly at which trials showed benefits and which outcomes, but I think we're going to skip this slide for a little bit. All right, we do need to talk a little bit about safety. I'll take the next slide. So in terms of SGLT2 inhibitor safety, I'd like to refer you to last week's talk for details. Last week, we did get a number of questions about lower limb amputation, so I thought we'd spend a little bit of time addressing some of these questions today. I'll take the next slide. Now, lower limb amputations, as you recall, a signal that was seen in the Canvas trial, but did not occur in any of the other CV outcome trials. It did show up in some pretty large observational studies as a doubling of risk. And these were primarily very, very distal limb amputations. So in Canvas, we're talking about kind of midfoot, distal foot amputations primarily. And we now have multiple observations that don't show an elevated amputation risk. So these are data from a Canadian cohort study pulled from multiple provinces, an absolutely huge study actually put together by the folks that do drug safety surveillance in Canada. And this study essentially compared SGLT2 initiators to DPP4 inhibitor initiators and found no increase in the risk of amputations following initiation of these agents. It's on the basis of meta-analyses of the randomized trials and on emerging observational studies like this that the FDA in the States has actually removed its black box label for amputation in canagliflozin, although the warning technically still exists on the Canadian labeling. But the overall point here is for your general patients who show up in clinic, who have an indication for cardiovascular risk reduction, the theoretical risk of an amputation, which is an uncommon event in this day and age, regardless, should probably not sway you too much against starting things like SGLT2 inhibitors. You really do need to get them on cardioprotective agents. Now, I will point out a caveat to this literature, as observational studies like this have routinely excluded patients with a previous history of amputation. So we don't have evidence specific to the patient who comes straight out of orthopedic surgery, missing half their foot, right into your clinic where you got to get their blood sugars under control. So we don't have amputation data specific to that patient. But what I can tell you is that patient is more likely to have CKD and establish atherosclerotic cardiovascular disease. And so we do know that patient's going to have some decent benefit from newer agents. It's a matter of balancing the uncertain risk of making their foot worse with the known benefit of, in terms of heart and kidney protection, of SGLT2 inhibitors. And I think that's an individualized decision, but I definitely think there's a role for involving diabetic foot specialists and following the patient up serially in terms of getting them on cardioprotective agents in a safe way. Okay. We'll go on to the next slide. This is just a reminder, SGLT2 inhibitors, don't forget to counsel your patients on sick day management. The SADMANS acronym is a great tool the Diabetes Canada puts out in terms of agents that should be stopped if patients undergo a dehydrating illness or an acute intercurrent illness where they can't eat or drink or maintain their carbohydrate intake. As you recall, this is primarily for the SGLT2 inhibitors to prevent hypovolemia and euglycemic DKA. Okay, I'll take the next slide. Again, this slide is reproduced from the previous talk. Refer you to the previous talk for details, but we'll move on, I think, to GLP-1 receptor agonists. Okay, GLP-1 receptor agonists. So in terms of safety, there is the theoretic risk in the literature of medullary thyroid carcinoma. This was a signal seen in rodent models, essentially. And as a result, all the trials of GLP-1 receptor agonists have taken to doing things like measuring calcitonin levels, just to make sure there's no increased risk of medullary thyroid carcinoma associated with GLP-1 receptor agonist therapy. As a rule of thumb, we say if patients have a family history of medullary thyroid carcinoma, we avoid prescribing GLP-1 receptor agonists. Now, medullary thyroid carcinoma, just so you know, is actually quite a rare subtype of thyroid cancer. And patients with a family history of medullary thyroid carcinoma should be quite obvious, because these are usually multiple endocrine neoplasia clusters that are well followed by healthcare professionals, including medical geneticists in the community. The more important thing to point out here is that human thyroid glands don't really express the same receptors that rat thyroid glands do. And so in humans, the risk of medullary thyroid carcinoma remains mostly theoretical. But you do need to avoid GLP-1 receptor agonists in patients with an elevated risk of gastrointestinal side effects. So for example, in my diabetes patients who have symptomatic gastroparesis, I have a lot of trepidation about starting GLP-1 receptor agonists. And the reason for that is, I'll take the next slide. The rate of discontinuation of GLP-1 receptor agonists, even under ideal trial circumstances, was about 10 to 15%. And that was primarily due to gastrointestinal side effects. So that would be nausea, dyspepsia, constipation, diarrhea, belching, reflux. Again, 10 to 15% of patients in the trials could not tolerate the titration and had to discontinue the agent. And this is something you do need to warn your patients about. This is also why we have such complicated dosing regimens in terms of titrating GLP-1 receptor agonists and getting patients to target dose. And that's to make these GI side effects tolerable for patients so that they can get to a therapeutic level. Patients do get used to these over time. And once patients are at a target dose of a GLP-1 receptor agonist, the rate of discontinuation thereafter is quite low. So they stabilize, the symptoms go away, things become quite manageable. In SUSTAIN 6, there was a signal of increased retinopathy in patients on the semaglutide arm, about 76% relative risk increase. As it turns out, if you dig through the literature, you can find similar increases in retinopathy after starting insulin. And the thinking here is that there is a treatment-induced retinopathy that occurs if you drop someone's blood sugars in a rapid fashion. We typically don't recommend any particular special precautions in terms of eye disease, except to make sure that patients have undergone routine yearly eye examination. If you have a patient who hasn't, that's okay. You can still start the GLP-1 receptor agonist. Most of us would just recommend that you start the titration and then you tell your patient, look, you're overdue for your eye test. In the next month or so, please just go to Walmart, go to LensCrafters, book your dilated eye exam just to make sure we know what's going on in the back of your eyes. But it's okay, you can start this agent for blood sugar lowering. GLP-1 receptor agonists are not associated with any increased risk of hypoglycemia. The modern GLP-1 receptor agonists, the one we use these days, have not been associated with an increased risk of pancreatitis, although some studies have shown a little bit of an increased risk of cholelithiasis. So a very modest increment, something to watch out for in certain patients. All right, so that was a run through of some of the safety information. This is the guideline slide duplicated that we went over in a fair bit of detail, so we'll just skip past it. And this is just a slide to point out that despite the guidelines, there's still a lot of room here to personalize your diabetes care. One thing that we personalize all the time is the choice of target, HbA1c for patients. And in patients who are functionally dependent or more frail, or you worry about the risk of hypoglycemia, we do tend to pick higher HbA1c targets, up to 8.5%, for example. Now, in terms of getting them on newer agents, I feel like there's two schools of thought about this, and I'd be keen to hear what Drs. Yeung and Manca think about this later on. You could argue that the newer agents are safer than being on a sulfonylurea or repaglinide or insulin for glucose lowering. And so they might actually be agents that you go to in your more frail patients. You could also argue that your more frail patients aren't going to be as able to tell you about the side effects like the nausea or the hypovolemia from SGLT2 inhibitors. And that might be the patient that you decide instead just to maintain the status quo if you're achieving a modified HbA1c target. So again, there's a lot of room here to individualize your decision-making in terms of getting patients on newer agents, tailoring diabetes therapy with respect to their cardiovascular comorbidities. All right, I think that's all I had to say for now, and I'm going to let Dr. Manca talk a little bit more about the case.
Okay, so back to our case with Mr. Nair. So his appointment was booked as an urgent appointment because he completely ran out of his medication. Frustrating. The typical behavior, you prescribe him an amount of medication and ask him to come back for a booked appointment before he runs out. However, he doesn't, and he runs out of his medication and comes in as an urgent appointment. And unfortunately, that often results in him seeing different doctors in the clinic who then will give him 3 more months of the prescription. And there was one time where you didn't see him for a year. So you really weren't addressing his problems. And this health-seeking behavior interrupts personal continuity of care, which is a problem. Next slide. So when I see patients, I think about what I call ABCPs. And that helps me sort of prioritize the issues, especially with complex patients, or what I call elephants. Do you eat an ant? 1 teaspoon. So he's an elephant. He's got lots of complexity here. And you're not going to deal with everything on one visit. So what does A stand for? Well, A is always deal with the acute problem that the patient presents with. In this case, refills. Easy enough, right? B is behavior. With him, I definitely want to change his health-seeking behavior. And I may address some other lifestyle behaviors if he's ready to go there. C, chronic conditions, and he has many, but the most important one right now on this visit is his diabetes. P stands for prevention. So when you have time in these appointments, then you think about prevention. I often look at the schedule before patients come in, and I set up forms and referrals, and then it's easy enough to squeeze into the appointment time at the time of the visit. Next slide. So continuing on discussion around behavior, he was concerned about his increasing abdominal girth. And when I asked if he'd be interested in hearing some of the new dietary approaches that I've heard about, he was open. So we chatted about different approaches that I found worked with other patients, such as lower carbs, intermittent fasting, increasing some of the healthy oils in the diet. And he thought these could work for him. So sent him, some information about resources that he could use around that. With his self-seeking behavior, I let him know about my frustrations. And we decided to try a different approach than, having him make up follow appointments, because he's a busy guy, right? We decided that at the time he leaves the appointment, before he leaves the office, he'd book an appointment. And if he forgets, I'd have my staff call him and book an appointment. Next slide. So to address the chronic conditions, particularly the diabetes, we were interested in optimizing his medications. And we just, had heard some great talks from some diabetologists. And we thought glycoside isn't ideal, but it would be good to trial him on an SGLT2, so plavaclozin. He has Blue Cross coverage and he'd qualify. We've already trialed him on metformin for over 6 months, and his sugars aren't great. And we trialed a sulfonylurea. If his hemoglobin A1C was adequately controlled, I might document some side effects from the intolerance to the sulfonylurea if I had to do that. He has a documented history of cardiovascular disease, so I can easily fill in the Blue Cross form. It's doable. It's a pain, not fun, but doable. With dietary and medication changes, we know his blood pressure can get infected or decreased, right? So this is something that he is to monitor at home. He's aware of this and he will notify me with concerns. For prevention and screening, he was given a rec for his blood work, and to follow up in 3 months, he booked the appointment upon leaving, which was great. And we had set up an appointment with his ophthalmologist. Next slide. He comes back for his booked appointment. Great. He didn't run out of medications and he lost 15 pounds over 3 months. He says it wasn't intentional, but he did change his diet and he was using intermittent fasting and he was not as hungry. He did complain that his skin was loose around the abdomen, and it was, but we thought it was a good thing. His blood pressure is on the low side. You can see at the visit, but he had no symptoms of hypotension. However, hydrochlorothiazide isn't great, and we could let that go. So we decided to stop that. He did indicate that when he was at the 25 milligram dose, he had ballantitis, so the tip of his penis was irritating him. However, when he cut down to 10 milligrams, that and other side effects he found quite tolerable. I did do swabs on Candida and they were negative, and nystatin didn't improve his symptoms. So Rose, maybe you can tell us a bit more about meds.
Yeah, so Donna, that is quite a remarkable case. And I was super impressed to see his A1C go from 8.5% to 5.6%. I have to admit, I do not have many of those type of success stories. So I'm very glad to hear your patient is doing so well. But, going back to what we've discussed in this talk, I think that when we look at patients who have existing cardiovascular disease, we really have to focus on the organ preserving medications that are now available. And my approach is really to do shared decision making and to let them know what kind of risks and benefits these types of medications have. There is a neat app that you can download called the Magic app that was just published right hot off the press off BMJ, looking at the medications available for diabetes with these cardiorenal protective mechanisms, and they give you nice breakdowns of the numbers for different side effects. And so these are useful tools that you can use at the bedside if you have somebody who wants to look at the numbers with you. And just to review, I've created these snapshot slides that have been adapted from the Diabetes Canada guidelines. And so the SGLT2s, they reduce the glucose, the weight, the blood pressure, and there is a negligible risk of hypoglycemia as monotherapy. But we have to remember the genital mycotic infections. We have to remember to sick day counsel and stop for surgery and illness. We have to make sure that people who are on insulin understand there is increased risk of diabetic ketoacidosis. And especially also if they are on very low carb ways of eating. We have to be aware of hypotension and adjust those BP meds to make sure that no one is fainting or falling over. And we need to make sure that they have good foot screening and education. We can maybe expect a little bit of an increase in LDL at times. And we can expect a decrease in their GFR when starting. So we suggest to monitor the SGLT2s 1 month after initiation, not sooner, unless you have other medical reasons to check it sooner. With regard to GLP-1 receptor agonists, these reduce glucose, weight, blood pressure, and one thing I want to emphasize is negligible risk of hypoglycemia, because the mechanism of action of these drugs is related to having ingested glucose. Okay, so these drugs work when people eat. They are GLP-1 receptor agonists do not have much action when there is no eaten food in the system. So this is really important to know and be aware of. And once again, the cardiac and renal protection we have reviewed. We've talked about the significant side effects of nausea and in some cases vomiting, but often related to dose. So dosing is really the key, and to start low and go slow. We know that A1C lowering is better with the longer acting agents. We have to be aware if people are complaining about abdominal pain, we have to keep an eye on their gallbladder and look out for gallstones, and not give it to people with any history of multiple endocrine neoplasia. But I want to note that papillary thyroid cancer is very different than medullary thyroid cancer. And as an endocrinologist, I get this asked sometimes. So I just want to clarify that these are distinct, and it is okay to use GLP-1 receptor agonists in individuals who have had papillary thyroid cancer. We want to also focus on all the important pillars of health. We want to make sure they are looking after their nutrition, their physical activity, their sleep, their stress reduction, and their social connectedness and purpose. So, you know, I hope that when you're talking about healthy behaviors with patients, to keep those pillars in mind and put them in context when we are trying to talk about medications, and linking the use of medications to promoting their ability to function and their ability to look after some of these other aspects of their life in an integrated way. Darren?
Okay, I will continue the roundtable. Comes back to me for a brief little Darren's thoughts here. So the thing that strikes me about this patient is, as a patient with a previous history of myocardial infarction, he is actually at incredibly high risk of a recurrent CV event from a population perspective. And this is demonstrated in the CV outcome trials. If you just look at the placebo group, how high is the cardiovascular event rate, even only after 2 to 5 years of follow-up in these trials? It's incredibly high. And this is despite most of these patients being on statin therapy, ACE inhibitors and ARBs, and having mean LDL controlled to 2.00, which is the CCS guideline. So again, this idea that no matter what we've been able to do for our patients so far, there's still a vast iceberg of residual cardiovascular risk under the surface for patients like Mr. Denier. I'm very gratified that he has the A1C down, and he has empagliflozin on board now, so he'll have that 15% relative risk reduction, CV risk from that. I guess my question is, why don't we do more for him because of that residual risk? This is a patient I would actually prioritize escalating his therapy with a GLP-1 receptor agonist. I know his HbA1c is 5.6%. I'm doing it for the cardiovascular benefit. I might not push him to the full 1.0 milligram dose of semaglutide. I might be satisfied with 0.5. But why shouldn't I give this man the additional 15% relative risk reduction in CV outcomes with that combination of both the SGLT2 inhibitor and the GLP-1 receptor agonist, right? If I do start semaglutide, now Mr. Denier is not on a DPP-4 inhibitor, but when you do start a GLP-1 receptor agonist, you have to stop the DPP-4 inhibitors, so your sitagliptin, saxagliptin, linagliptin, if they're on it, because the mechanisms cross over. And as a rule of thumb, we say that combination is probably not useful and might increase the risk of side effects. Smoking cessation, he needs to quit smoking. Again, how can we get at his residual risk? He's already on max dose statin therapy with LDL at target. That's wonderful. His BP is at target. That's wonderful. This is a bit beyond the scope of this talk, but I would like to highlight an emerging treat to target, and that is triglyceride lowering. It's making a comeback. And this is based on the new CECS guidelines and the result of a pretty high profile trial that just came out in the last couple of years. And that trial was the Reduce It trial. Reduce It randomized patients to an omega-3 purified formulation called icosapent ethyl, marketed as Vascepa. So this is actually a new drug entity versus placebo. And there were some pretty substantial benefits in both relative and absolute terms in terms of CV risk reduction in patients with pre-existing cardiovascular disease and in the diabetes subgroup as well. The inclusion criteria is patients with elevated triglycerides, so 1.5 to 5.6 millimolar per liter. So in this patient, Vascepa is something you might consider if you get him on maximum therapy otherwise, and he still has elevated triglycerides. It might be something you consider. The only downside about icosapent ethyl is that we're talking about a cost of $360 a month. So even with drug coverage, he's going to end up paying a fair chunk out of pocket. Again, a bit beyond the scope of this talk, but something I thought I'd give you the flavor for. The field of residual risk reduction in terms of cardiovascular prevention is moving quite quickly. And you'll start catching wind of these sorts of things, either from your pharma reps or even from the CCS guidelines. Okay, that's it for my thoughts.
Okay, we're going to move on to the panel. How do we move from individual patient to a really assessing a panel of patients? And data is really important for us to do this and improve the quality of care we provide. Regulatory bodies such as the College of Physicians and Surgeons are now beginning to require us to report on quality improvement activities. The Canadian Primary Care Sentinel Surveillance Network extracts and cleans data from electronic medical records for purpose of surveillance, research, and quality improvement. And there are a number of practice-based research networks contributing to it. My network is the Northern Alberta Primary Care Research Network, and there is one in Southern Alberta as well. So there are two in Alberta with the Departments of Family Medicine. We can take the data out of your electronic medical record, clean and structure it, and apply algorithms to it so that we can tell you who your patients are and which patients have different chronic conditions. So no matter how poorly you enter data into your record, we can give you back information. So it's a very rich data set, and you benefit from both contributing and helping family medicine and primary care research, as well as you get some benefits back, such as feedback reports and things like that. Next slide. So this slide is just a snapshot. It's actually of my own practice, so that you can see I'm entering 100% of my patients correctly in the problem list. So if I'm going to do a practice level intervention for diabetes, I'm going to get all of the patients. And that's because I've got the SIPSN information I can link and clean up my EMR. And when I do assessments in that, I've got a good amount of data to know how well I'm doing in terms of diabetic control. And, you know, the practice level interventions are good. My hypertension, not as good. I had cleaned that up a couple of years ago, and it's starting to drift. Now you can see how it compares, you know, so we can give you feedback on how your practice compares to the group that you're with, as well as with the all of the practices in the network. And you can see on average, only 67% of diabetes is correctly coded in the profile, so that only 67 of diabetic patients may be identified by a large majority of our family physicians. So that's probably not good enough if you want to do an intervention. Next slide. This is another snapshot. It's a diabetes overview, and it's an example of a feedback report that you could receive. This is my own feedback report. And I suggest, you know, when you get feedback reports, you have to use caution in interpreting the data, because it is unique to your own practice. And you can look at this and think, oh, this looks really good. But you have to understand that I've been doing this for a while. And what I was doing was looking at really capturing weight. So if you look at the weight, you'll see that I've got 100% of patients that have weights documented. And I've been doing it on non-diabetics as well, and addressing, patients that are overweight as well as obese. So I'm catching diabetes probably a little earlier, and it's probably making my profile look a little better in terms of the diabetes control. So when you do quality improvement, these kind of data can be very helpful for you. Next slide. This is a slide that the three of us have been working on. It's research, and you can see that it informs you about how we are prescribing these newer agents. And you can see that, based on our talk, we probably should be prescribing more of these newer agents to patients with heart disease or kidney disease. But when you compare it to patients that only have diabetes, they're getting less, right? They're being prescribed less. Now, there are many reasons for that. So you can't just judge it right off the hop. And this is for more research, right? One thing is they may be on more insulin, and then we may be uncomfortable prescribing because of insulin. So there can be a multitude of reasons for this. So it's important to look at it, and if we should be prescribing with insulin, then it's educating, so finding out more and how to improve things is really important. Next slide. The Department of Family Medicine, we've been working on developing resources for practice improvement, and our residents are required to complete 2 quality improvement projects through their residency. Now, to facilitate that, we've put together a manual for them, a resource manual that has a lot of details, and you will get a link to that. We also have a faculty manual that can assist faculty in supporting residents, through their quality improvement projects. We put together resources as well. So those of you who have a resident, if you're interested in improving your practice around diabetes, we have some resources, and we have things like a process map that you could use to reduce sulfonylurea, as well as links to deprescribing algorithms and lots of resources that could be used. And I'd really love to see our residents do more meaningful improvement. And this is a great area to do it in.
All right, so I guess I'll just provide some wrap-up points here. Thank you, Dr. Manca and Dr. Yeung. So our take-home messages from the talk today. We've spent a lot of time introducing SGLT2 inhibitors and GLP-1 receptor agonists and talking about the cardiovascular benefits of these agents. Please remember to prescribe these agents based on cardiovascular risk, regardless of HbA1c. That's the new paradigm here in diabetes world, is that we try to get patients on agents with end organ benefit if they have elevated end organ risk. Don't forget your sick day counseling for SGLT2 inhibitors. Can't underestimate the importance of SADMANs. As somebody who sees a lot of inpatients coming with complications, can't underestimate that little bit piece of counseling there. Get your patient back into clinic. Global CV risk reduction is a process, and I know the tricky thing here is that it's easy to sort of start an agent and then fire it off and forget about it. But it's ideally, the best progress is made if you can build that relationship, get that patient in the clinic, and work on things piecemeal, one step at a time. Okay, and a bit of a call to arms here. Collectively, our common challenges: we have new agents. They have the potential to really benefit patients in terms of end organ benefit, CV and renal protection. Now, how are we going to get everybody at elevated CV risk on these agents? And so I hope you will take a moment to reflect on your practice and think about what we can do collectively to try to bridge that gap between what we know and how we practice. And don't forget that if patients are on insulin, secretagogues, DPP-4 inhibitors, or diuretics, there are some interactions with the newer agents in terms of hypoglycemia risk or crossed over mechanisms or risk of overdiuresis. And so you do have to think about adjusting or deprescribing other agents if your patients are quite tightly controlled, for example. And we're going to talk lots more about that at next week's webinar, so stay tuned, please. Okay, I'll take the next slide. Okay, don't forget, guidelines.diabetes.ca, your definitive source of all things Diabetes Canada. And here's some more links for you. And there you go. That's the next talk next week. Okay, I think we'll stop there for questions. We're just a little over time, but back to you, Dr. Abraham.
Thank you so much, everyone, for, again, another very informative talk, and we've got some great questions. I think given the time constraints, we'll probably maybe just address maybe a couple of them. I know Donna's trying to answer one of them because Cheryl asked some great questions, and so I think Donna was addressing at least one of them. There's a couple here that I just thought I would put out maybe to, let's go to Darren. Is there any published data on the use of SGLT2 and GLP-1 together?
The answer is yes. Why don't I, if you're gonna stick around for the next talk, unless Doctors Yeung and Manca have any specific data to refer to, but why don't you let me do a quick look up on that, and I'll get back to you about the results of that next week. All
right, TBD then. Then I don't know if Donna's still typing away, but for Rose, if a patient is on a target ACE inhibitor or ARB for kidney protection, blood pressure control, and already on an SGLT2 inhibitor for kidney protection, should an albumin creatinine ratio still be done yearly? And if so, for what reasons and why?
That's a good question. I think that I would still do it yearly because these patients can still decline. So I think it's still just safer if they're getting yearly blood work to just throw on the screen and have some assurance that their kidneys are stable.
Just as a reminder, we appreciate everyone's feedback, just in case people are sort of trickling out. You can use the QR code here. Please take a few minutes to complete the evaluation form. So you can always scan the QR code that you find here or visit the website that's there in the on the slides, but we will also be putting it in the chat box for you to access. And I guess, I don't know, Donna, but I guess Darren or Rose, any difference in metabolism for GLP-1 receptor antagonists in different races? Sorry, agonists.
I haven't seen any data specific to that, but I haven't looked, to be quite honest. So I'd have to look into that. Darren or Donna, have you seen any?
That's a fascinating question, and I haven't seen any data for racial differences yet either. That's something we might have to poke into a little bit, actually. That's a fascinating.
Yeah, because I've seen some data on DPP-4 inhibitors potentially being more effective in East Asian populations. There was some work in Japan that was looking at that, but I haven't seen anything recently.
I'd be very interested in the indigenous groups.
Yeah, it's true. There are polymorphisms in different ethnicities that do have differing effects. So that's a really interesting question.
Just as a plug for some of the work being done in lifelong learning, we'd love to, many of us would love to work with you on co-creation projects. So if you're interested in volunteering with the team, you can also visit this QR code and the website over here, and we will get in touch with you when projects match your practice. An interesting question here. If someone with retinopathy is, say, on semaglutide and has worsening retinopathy shortly after, would you continue the drug and assume it would stabilize?
My answer to that question is yes, but I would refer to an ophthalmologist 100%. Do whatever the ophthalmologist says. And it may be a matter of increased monitoring, for example, or they may actually need a little bit of lasering to be done.
Yeah, I would also figure out whether the rate of glucose control, like the glucose decline is too quick. So it may be a matter of slowing down the glycemic control. And it may just be, with regard to dose adjusting medications.
And lastly, I think we have here from Cheryl again, any studies of effect of any of the oral medications on the gut microbiome?
I have not seen any data on that. Also very interesting question. Good questions. Some things to look into for next week.
Yeah, no, for sure. These are some actually some very interesting questions that I'm hoping we can address for everyone when you all return next week for the 4th webinar.
That's right. And so in your evaluations, please do let us know if you've got questions for future topics. If we have a chance, you might get it bonus inserted into next week's talk. And stay tuned. We look forward to seeing you online.
So that looks to be all the questions. If anyone has any sort of final burning questions, you can always, again, as Rose mentioned, you can always put it in the evaluation form. But it was a pleasure seeing, or at least virtually, having all of you here. And we hope to see you again for the webinar next week.
Now, I know, I think Cheryl did raise an interesting point in response to my comment about triglyceride lowering. I think Cheryl said, well, why don't we call the registered dietitian?
Yeah.
And Cheryl, I 100% agree. Triglycerides are one of those things that are exquisitely sensitive to carbohydrate reduction in diet, better glycemic control, and reduction of alcohol use as well. So, given how expensive icosapent ethyl is, I would typically make sure the statins are maximized, exhaust the dietitian route as well, get the blood sugars under control before thinking about starting something like icosapent ethyl. And that's partly because of some uncertainty related to icosapent ethyl. This is the subject of a whole other big thing, and maybe one day we'll get around to doing a talk about cardiovascular risk reduction. There is a fair bit of uncertainty about using icosapent ethyl right now in terms of different opinions here. And anyways, the point is well taken.
I think Cheryl had some excellent points around the team. And this particular patient had a personality that was the behavior I was trying to address. Our patients are very fortunate because we have a dietitian that we can consult, and others on the team. Like, he had cardiovascular people involved when he had his heart attacks problems where he just doesn't show. But maybe over time that can shift. I think we're very fortunate with our PCNs, with the resources that we can tap into, and always being aware of that. There are other dietary things with him too when he was drinking a lot of alcohol, because I often worry about the thiamine and that as well, so yeah. So the more heads together, the better.
So thank you and good night.